Yeah, good afternoon everyone. So I've been given the opportunity to introduce one of a very renowned person. I was trying to correlate how the physical activity is related to microbiology, and here today we find that physical activity is very important in a way to keep our gut healthy, and once our gut is healthy we can definitely resist many of the infections. So today we have among us one of our person. I would start with a champion in Commonwealth powerlifting, Asian powerlifting, national powerlifting, as well as Delhi state powerlifting. A lady with a very big sports activities all throughout her journey. Dr. Dimple is an MBBS graduate from Jammu and a postgraduate from a gold medalist postgraduate from Bangalore. After that, during her post-graduation, she joined Ministry of Health and Family Welfare after clearing UPSC examination in National AIDS Control Organization at Delhi as a Deputy Director. After having worked with AIDS Control Organization, then now she has moved to one of a very important organization of the country, Central Drug Testing Laboratory, which is as a Director, Central Research Institute, Kasoli. And most of the vaccines before authorization for their marketing are being tested for all quality control and quality assurance parameters there at Kasoli. So the topic selected for Dr. Dimple is truly very, very relevant to her experience and exposure, vaccination and hospital-acquired infection. So I think we people are really privileged. Thank you very much, Dr. Dimple, for sparing your valuable time and arriving at SGT University for such a beautiful this insight on vaccination and hospital-acquired infection. A big round of applause for Dr. Dimple. I welcome you on the board. Thank you.
Pioneer in the field of vaccines and antivenom manufacturing. Government of India has 4 vaccine institutes, out of which Central Research Institute Kasoli is the biggest one, and that is a place from where the vaccination actually started in India. The first rabies vaccine came through the CRI Kasoli. First director, Dr. Semple, was the one who came out with the rabies vaccine. Before that, people had to travel to Paris to get the rabies vaccination done. That was during World War II, and that used to cost 30,000 rupees during that time. So making a vaccine indigenously at India per se saved us a lot of cost, and of course it brought a lot of laurel to India in the world of science. With that background, it did not only start or stopped at the rabies. There was a time when almost every 4th vaccine was coming from the Central Research Institute Kasoli. We were making typhoid vaccine, we were making sheep brain rabies vaccine, which was there earlier. The technologies were different. There was no requirement of the GMP facilities, which came out much later. So typhus vaccine was the one. Typhoid we were making, yellow fever vaccine, Japanese encephalitis vaccine, diphtheria group of vaccines, pertussis, tetanus, DPT. All those were made at Kasoli, and right now also we are making DPT group of vaccine and TD vaccine. Yellow fever vaccine is also, now we don't make it because buying from China comes out much cheaper. So WHO buys it for us, but we supply to all over India. Yellow fever vaccination center is in the Kasoli. So anybody traveling to the eastern countries or where the yellow fever vaccination is needed is provided from CRI Kasoli. Along with that, we make anti-seras which are acting against the snake bite, that is anti-snake venom sera. We are making the anti-sera against diphtheria, which is ADS or antidiphthetic serum. We are also making the anti-rabies anti-sera, that is ARS. So all these products are there. Along with that, we are a reference center for E. coli and Salmonella. All the diagnostic reagents for identifying the cholera or the typhoid are made at CRI Kasoli and supplied to various parts of India. So this is just a mini background from where I come and the institute I represent. And I'm glad to be here today at SGT University to share a part of our institute with all the young and budding minds and of course the stalwarts in the field. So it's my proud privilege to talk about something which is very close to my heart, that is vaccine and hospital-acquired infections. Though they might seem different terms, the hospital-acquired infections or vaccine, if you think in one go, they may not look related to you right now, but they are. So I shall cover my talk under these headings, which of course will go one by one. So first of all, we'll start with the very basic, that is a definition of hospital-acquired infections. So as we all know, the hospital-acquired infections are the infections which patient does not have initially, but he gets these infections as soon as he enters the hospital. That is the infections which are acquired within 48 hours or more after the hospital care begins. More means if the patient is for the surgery, so any infection up to the 7 days post-surgery is also defined as a HAI or the hospital-acquired infection, and they should not be present at the time of the admission. Significance of immunization in infection control, like that is how we are trying to correlate vaccine and the HAIs. Vaccines are the primary preventive tools. We normally give these vaccines to prevent against certain diseases, like it will be BCG for the tuberculosis, or it is DPT as we talked about against the diphtheria, pertussis and tetanus. But they indirectly benefits along with the certain other conditions like the AMR. In the morning session we did hear Dr. Marlin talk about it, that indirect benefit for lowering the AMR, we have the vaccine which should play a major role in that. And it also reduces our requirement for using the antibiotics, the prime cause of having the AMR. The common types of HAI, that is, of course, just for the beginning, for the students, I would like to elaborate this. There are 4 types: the urinary tract infections, the surgical site infections, bloodstream infections, and pneumonia. This is how the HAIs are classified. UTIs are the most common HAIs, that is the urinary tract infections. They are often affecting the patients who use the catheters in the hospital setting, so they have to use the catheter after hospitalization. Surgical site infection, as the name itself says, they are the post-operative infections and then can lead to the severe complications, making prevention critical in medical facilities. Bloodstream infections, they are the infections that are linked to the IV catheter use. So any patient who is admitted in a hospital and where we are using the intravenous devices, they can turn to be life-threatening. And then they require the prompt diagnosis and treatment for letting it spread on patient going in coma or the sepsis. Pneumonia is a very significant HAI and it can affect the patient in hospitals, particularly those on ventilators or with a weak immune system. So generally the patients who admit in the ICU, their immunity goes down. So in such conditions, if their immunity is low, the chances of getting the pneumonia is very high, and these pneumonias are not normally with which the patient has actually come to hospital. The basic disease is different, but this is a secondary infection which is acquired due to the hospital admission. The various pathogens which are involved in HI, though there are multiple number, the list is very long, I am just enumerating very few. The gram-positive pathogens are the Staphylococcus aureus. It can include both MRSAs and MSSAs, that is methicillin-resistant Staph aureus, along with the methicillin-sensitive Staph aureus. They both can cause HIs. Enterococcus faecium is another one. Gram-negative pathogens, we have the most common as the Pseudomonas aeruginosa, Klebsiella pneumoniae, and for the enumeration sake, if you say the viral pathogens, they are the influenza is a very, very common condition which you can see with the HIs, and so is the SARS-CoV-2. Clostridium difficile, we did hear about it in the morning lecture too. I again would mention it. It is linked to the antibiotic uses and it is associated with the immunosuppression. So most of the times the primary infections are not due to Clostridium difficile, but if the patient in the long-term antibiotic uses, you should suspect the Clostridium difficile. Klebsiella pneumonia are associated with the ventricular associated pneumonia or VAP as we call them. Global statistics, that just to give you a larger picture how it affects, how economy gets affected with. Prevalence of STI even in the developed nation is from 7 to 10%. The mortality is even higher. In the US alone it has reported 90,000 deaths in a year. So you can think of the countries where we are not even enumerating them. So we are not enumerating does not mean it is not happening. It is happening in much bigger number, but the only thing we are obvious to that, or we are not doing that larger study to actually say the numbers. So what could be the strategies? We know there are too many harmful effects are getting, the patient is getting the disease which is very difficult to treat. How do you actually control the high hospital acquired infection? So I would like to emphasize here, when you say the combating HAI, we cannot stop it to totality. We cannot say the HAI will be nil or there will be no hospital acquired infections. We have seen the example of USA in the best of the cases, 4 to 7% to 10% is the one which is accepted rate even in those settings. So if we see the realistic picture in Indian scenario, where we of course do not have the best of the healthcare facilities, our population burden is more, so our burden of HI is also more. So we can only think of the strategies which can help in reduction, but not saying it will go nil. So first and foremost, of course, is the infection control measures we should take. The rigorous infection control measures are very crucial to reduce the HAIs and ensuring the patient safety. We can introduce a vaccination program which is right now are there but not as totally accepted as a government policy. It is there in certain hospitals and some hospitals just do not follow it at all. So it is a variable picture. In some hospitals you would see there is a policy, and since it is not mandated by government, so some just can go through it without having any infection policies. This vaccination program does not mean it is only for the patients. It is for healthcare workers also. So we have to have a vaccination program. The policies which an institution can make, it can be made for the healthcare workers. Along with that can also be made for the patient. The continuous monitoring is one part which a microbiologist should definitely be seeing into it, or they should be actively involved in this. They have to continuously monitor, that is keep doing the surveillance and see what is the infection rate in that particular setting. It varies from hospital to hospital. It varies even in the hospital ward to ward. It will be more in the surgical side, it will be more in the medicine side. It may not be as much in the dermatology or say the dental setups. So it varies from particular location where we are doing the surveillance. But to know and to stop, we actually have to have a figure. So this has to be a round the year activity. Team collaboration is must. Even if I have the willingness to do it, I want to control it, but I do not have administrative support, it will be very difficult to do that. So that is why we have to have a team management here. The team means my admin should support it, the infection control nurses should be there, my healthcare workers should be aware, and so is the patient. So mechanism of immunization, that is how the vaccine coming into picture here. The vaccine functionality, that is just for the basic part I want to cover, that they work by stimulating the immune system to recognize a specific pathogen and then enable a faster and more effective response when exposure happens. Antibody production, which can happen naturally with delayed response, but if you are giving the vaccination, the antibody production which neutralizes the pathogen provides immediate protection against the infection. We do have a memory cells which remembers the infection which has happened in the past, or if you have given the preventive vaccine, they know the memory cell would remember it. So when the actual exposure happens, the response would be much more faster. Importance in the healthcare is because the immunization is crucial in hospital settings to prevent the healthcare associated infections. It helps in safeguarding both patient as well as the healthcare worker. It is important to immunize both because it is not always that is patient is giving the infection to the healthcare worker. It is two-way system. Even healthcare workers give infection to the patient. So to prevent that, it is important that we cover both the categories. So immune boosting and vaccine preventable HAI. It's not that every kind of HAI will be prevented because of the vaccines. So it is not all or none phenomena, but of course we can control. We can have the immune boosting or we can have the vaccine preventable, those two bigger categories. In the immune boosting, vaccine stimulates T and B cell response, and they also reduces the infection severity when it happens. Vaccine preventable HAIs are the ones which we have most commonly seen is the influenza, which reduces the secondary bacterial pneumonia up to 50%, that is 30 to 50% is the range. Hepatitis B vaccine prevents chronic liver infections in healthcare workers exposed to the blood-borne pathogens, or the healthcare workers who are working in the hospital care settings and are likely to get exposed to the hepatitis. Pathogen targeted vaccine are those which are specific to a particular pathogen, that is diphtheria and tetanus. Like the diphtheria vaccine is actually only for the Clostridium difficile, for the bacteria, where the tetanus is a toxoid which is helping prevent against the tetanus. It reduces the colonization and transmission, including influenza and the pneumococcus. So vaccination for the healthcare worker, that is, I'm not talking here about the patient, I'm talking about the workforce which is working in the hospital settings. For them, what a management should offer is the influenza vaccine, so that the transmission is reduced to the vulnerable population, that is the patient who are there in the ICU or the ICCU. Post-vaccination program shows at least a 60% reduction in patient influenza cases, which is a large number. So if your workforce is vaccinated against influenza, you immediately bring down the influenza rate in the patient population. Hepatitis B vaccine, as I said earlier also, it is very important that your healthcare workers are given the hepatitis B vaccine, especially those who are exposed to the sharp or the injuries of the blood they are dealing with. It provides immunity in 95% of the recipients, which is a very, very big number. So we have all the more cause and we have all the more reasons to go for this particular vaccine. COVID-19 vaccine is a recent addition. It prevents the outbreak of SARS-CoV-2 in hospital environment, and of course this is a very, very recent learning owing to the pandemic which we have all seen. Now the vaccination for the patients. For patient, pneumococcal vaccine which is readily available should be given, that is PCV13 and PPSV23 are the ones which are generally available in Indian setting also. It prevents the invasive streptococcal pneumonia infections, and also the leading cause of HAIs are covered by them. So they'll reduce the HAIs if they're given. Tetanus toxoid vaccine, we all know that it is essential for the trauma care. It is also important for post-operative wound care. So if the hospital has a policy, then they definitely will see the reduced HAI in their wards. Varicella zoster vaccine is not recommended for general population, but for the immunocompromised patient, this vaccine should be tried. It reduces the hospital-acquired infections which are due to the viral pathology. The influenza vaccination in healthcare workers, there is a study which was done, which is a 3-year-long study in a 500-bedded hospital, and the result shows 42% decrease in hospital-acquired infection when this vaccination was given to the healthcare providers. It also decreased the absenteeism. This absenteeism was because of the disease the healthcare worker was suffering. So if the vaccination is available to the staff, there is a 30% reduction in the staff absenteeism. Pneumococcal vaccine, it is, especially I'm talking about the ICU patients here, because pneumococcal vaccine in ICU patient has shown the reduction up to the 20%, especially in the VAP cases or the ventricular associated pneumonia cases. Another vaccine which I must mention is the rotavirus vaccination in the neonatal units. It reduces the neonatal gastroenteritis and the outbreaks of that in 40%, and rotavirus vaccination is important because this outbreak, it generally happens in the summer months. As the April-May approaches, in most of the Indian settings, you'll see this outbreaks happening. So what could be the best practices of immunization? One, of course, is a routine vaccination, that we can go for the routine vaccination of the healthcare workers, because that is a defined population. You know who all are working there. But another important aspect in that is the education and training. Without that, patients, even the healthcare workers, they will not come forward to get the vaccination done. So education and training is one which we should focus on, so that they come forward to get the vaccination done, and if it is not available, they at least demand from the administration for the vaccination. It's not only reducing their disease burden, it's also reducing the HAI burden, which indirectly affects the hospital and causes a lot of money. So economically speaking also, the institution should make the policies for the vaccination for the healthcare workers and for the patients. And when they implement it, of course, there is a reduction in the HAIs or the hospital-associated infections. So what could be the implementing strategies? How would we go about it implementing? So we know if you are giving the vaccination either in the population which is not affected by disease, that is a healthcare worker, or it is a patient who is already having some disease, but we want to prevent it against the added infections. So first and foremost, of course, is the mandatory vaccination policies, which can be made at the administrative level. The annual influenza vaccine for all healthcare workers should be prescribed. So is the hepatitis B vaccination and their compliance check. Compliance check means we have to check the antibody level in the serum. Vaccination clinics can be held for the patients, which can offer the pre-admission pneumococcal and influenza vaccine to the patients, and also the vaccination and pre-surgical protocols for high-risk patients. All this cannot happen if the patient is not educated or has not been trained and sensitized why this vaccination is important to him. Microbiological monitoring and surveillance should also keep on going side by side. They should track the vaccine preventable pathogens. They should tell you what is the trend using the PCR and other culture methods. And of course, they should identify the resistant strains, and they have to give an informed decision-making information to the management so that they make their vaccination updated policies and implement it also. So how do you overcome these barriers? What are those barriers? So vaccine hesitancy among healthcare workers and patients is almost the same. All of us are at the same level when we talk about the vaccine hesitancy. You must have seen and experienced during the COVID time also. There was a lobby which was totally against vaccines, and that included both. That included the healthcare workers, it included the patients. So same is here. So vaccine hesitancy is quite a common phenomenon which we'll see amongst both the categories, whether it's a healthcare provider or it is a patient. So solution to that is of course the education. You have to educate the both. You can hold the camps, you can have certain workshops, or you can have the round day trainings going on, so that there's a educational campaigns which highlights the data, and they give them the data which says how much efficacy that particular vaccine has proved and why it is beneficial for them to take it. Logistically, it may be challenged because we have to maintain the cold chain, and we have to probably the hospitals can devise a mechanism where each individual patient where the vaccination is taken, they get an automated response for the reminders when they have to take the vaccine schedule. Like for the hepatitis B vaccine, I know many hospitals have a policy in place, but the healthcare worker, they take first dose, but then they're absent for the second dose, and third dose is also missed. So if they get a reminder beforehand, say a week before they get a reminder, 2 days before they get a reminder, on the day of vaccination again they get a reminder, then of course the chances of them missing the second dose or the third dose are very less. So those kinds of mechanisms can be developed from each institution to institution. I'm not saying there has to be a larger policy, but at least institution-wise they can make it. Resource allocation, of course, for anything and everything you do, you need to have certain kind of logistics and the resources to fulfill that commitment. So we have to advocate for that. If it's a private institution, of course, where the management lobby is the place where you should go. If it is a government, you have to go to the government institution. If it is an NGO, you have to ask them, the NGO, to fund it. But we have to ensure from where the funds are going to come before you actually put a program. So what is the role of microbiology actually in the vaccine efficacy? First is, of course, the pre-vaccination, they identify the pathogen. When they collect the swabs from different areas of the institution, they identify which particular pathogen is predominantly found in which particular area. So they can use the various diagnostic tool to identify that. And once they identify that, they have to give the remedy. They have to inform the institution in charge, and they have to give the remedy for that. They can do the various kind of assays like molecular assay for streptococcus, pneumonia, or any other machine they are using. They can use Vitec, or these machines are available everywhere, even if it's not manually done. The post-vaccination surveillance is a must to know the efficacy. You have to monitor the serotype replacement and the AMR pattern which you are seeing in your setting, because these patterns would change from institution to institution, from geographical area to another geographical area. You have to utilize the whole genome sequencing part. These machines are now very common at post-COVID. Most of the institutions have got it, so you can get the facility done. If not in a remote area, then you can tie up with a certain institution who have the facility, so that the strain can be analyzed and you know where actually and what actually the measure should be. Vaccine development contribution, of course, you can have the role in that. You have the role in messenger RNA vaccine design. You have to identify the seed strain. You say that this particular pathogen is there. Once you've done the genome sequencing, then you know the particular genome sequence also. So the call to action is of course to the healthcare workers. They are the one who should come on the forefront to do this. They have to advocate for the vaccination program, not only in their own community but also to the patient and the relatives of the patient also. And they must themselves participate in vaccination program, because once they do it themselves, then of course the action speaks louder than the word. So if they are taking the vaccine, the patient would also go forward and take a vaccine. Hospital administrator as an administrator, their role is to first laud the efforts taken by the healthcare workers, and then they should invest in vaccines and the vaccination policies. They must include the vaccine in their infection control budgets, because without budget it is not possible. They cost a lot. Policy makers have to make a policy where it becomes mandatory for the healthcare workers to take the vaccine before they go and work in a hospital setting. They have to ensure the compliance in all healthcare facilities. So the various strategy for this could be that until preventive vaccines are available, infection control measures are crucial and should be strengthened. That is, we're coming back to basics. If we are not having the vaccination in place, because this is not going to happen overnight, the education, getting the mindset change will take a time. Till that time you have the vaccine available, till that time you have the policies available, till the time your administrator actually agrees to it, you have to take the strict infection control measures, and it is very crucial. Even when the vaccine is available, after that also you have to lay back that infection control measures cannot be neglected, and that should go side by side. As a spectrum of AMR is not limited to humans, so nowadays, since we know this, the importance has already been identified, we should talk about the One Health. So One Health response is necessary in this case also. That is in parallel to the development of the vaccine for humans. We should also work towards developing a vaccine for animals, and that remains crucial. Till that time we govern the whole spectrum, getting a success is not there. That's all from my side. Thank you all. Any queries or questions? No.
Thank you, Dr. Dimple, for a wonderful insight on hospital-acquired infection as well as the vaccination. I think some of the key lessons from her talk is monitoring is one of a very crucial factor. A healthcare team has to work collectively to look into the reduction, and we have seen that if we really take precautions, we can reduce even pneumonia infection by 50% and hepatitis by even 95%. So all healthcare worker has to collaborate with them. And as we know that India basically is a global head, particularly as far as the production of vaccines are concerned, and they are the exporters to more than 200 countries. And vaccination programs begins with immunization from a very infancy stage only. So thank you very much, in fact, for such a wonderful insight on vaccination and hospital acquired. Now the session is open for any query or question if anybody wants to ask from Dr. Dimple. Yeah, please.
Hello ma'am, I really love this session and I completely agree with the points that you mentioned, but my question would be, what is your idea of practically implementing a reduction in HAI among rural India given the lack of education, resources, infrastructure and sensitization among people?
As I said, the change is a very slow process. It doesn't come overnight. So ultimately, educating your workforce is the answer. So even if you tell them the continuous education is must, as you said, you have to hold, even when you are educated enough, I'm not talking about the rural population only, even a healthcare worker, when you're educated, it is considered that you are the one who has an open mind, you know it, then also we need to do the education and the policy. We have to educate them, call them, repeatedly tell the same thing. If it is that only the rural population does not understand, that's a false statement, because during COVID time you have seen the people who are educated, people who were in the medicine field doing the service in the hospital, they themselves had a vaccine hesitancy. So rural population, of course, the same strategy. You have to educate them, the continuous education, telling them and giving them the actual data. how this particular vaccine has reduced this much infection in that particular population that you say. Like if I say if you're giving the hepatitis B vaccine, hepatitis B cases come down to 95% has been covered. So it's a 95% reduction in cases, a big kind of a data. So this is the actual figure, the realistic example, what is happening in and around their vicinity, then they probably would listen. We don't have to tell them a story, but of course, in a way of telling a story, you have to make a that nukkad natak or the folklore by which they can understand. You have to go deep down to their level, you have to talk their language and make it understandable at their level. So education and continuous education, that only remains the answer for rural population and for us also. Okay?
Thank you, ma'am.
Thank you, Dr. Dimple. I would slightly add in it, we have a very robust national health programs also and a lot of outreach activities by government of India also. So those programs also help the ASHA workers, and they are reaching deep into the rural areas, and then they are convincing the people. And that is why we succeeded in COVID, I think. Thank you.
Hello, ma'am. So my question again is related to finances and money, basically. So India has invested a lot on routine immunization, and it is continuing to invest by introducing new vaccines. With respect to vaccines and hospital-acquired infection, are there any studies or is there any research conducted by CRI or other organizations to look into the cost-benefit or cost-effectiveness analysis?
If you listen carefully in the beginning of my talk, I gave you the US figure saying we do not have a robust data from India. That means we do not have a larger scale studies, but smaller studies are there. If you look at into it, there are multiple studies done from the Suffolk Hospital and BMC. There are certain studies from Lady Harding Medical College. There are few which are from the RML, and MAMC also reported certain, but they are not covering the larger population or say are giving you the national picture. Regarding CRI does not have a hospital. It's an institution which makes vaccine and antisera. So hospital-acquired infections per se not applicable to that. We have something different which is known as a CGMP, that is the global manufacturing practices that we comply with. So those are different policies and those are different kind of a program which for which a vaccine institution to combat it. In a hospital setting, of course, you have a hospital care infection team. You have the HI teams which have the infection control nurses there which go round the clock, and they have the surveillance calendar actually in each hospital. I presume each hospital has it, but surveying, of course, I know that started way back in 1993, the first time of the survey. So they have infection control nurses. They have a calendar and a schedule by which they go to each ward, collect the samples, and then they generate data. Which institution has how much infection prevalence rate. So the prevalence data is circulated amongst the in charges. It is a big meeting at the administrator level so that the administrator is involved and he knows how much is the problem in their hospitals, so that the money is being allocated to control that part. So CRI, of course, is a different scenario. Since we have a CGMP, we cannot tolerate even a single microgram, right?
Anyone else have any question? Please, please.
Thank you, Doctor. It was a good talk. And then as we are talking about the One Health, and you talked about Streptococcus pneumoniae, I just want to bring to the notice of the whole audience that with the increase in the serotype, or we have Prevnar 20, or we are coming with more serotypes included in the vaccine. But there is an issue that there is decrease in the efficacy or in the effectiveness of the vaccines in Streptococcus pneumoniae. This is related to directly and indirectly to One Health also. But then there were some discussions among the collaborators or the scientists that why is it that we are increasing the serotypes of Streptococcus pneumoniae in the vaccines, but still the effectiveness or the efficacy is coming down. So as you mentioned, surveillance is very important. Serotype replacement is very important, and obviously these kind of talks are very important, and linking it to the scientific community for the awareness and also doing the surveillance programs. Thank you. I just wanted to bring to your notice. Thank you. Thank you so much.
Thank you very much. Over to you, please.
Thank you, sir. Thank you, ma'am, for your pristine words. I request Professor Vijay Bhalla, sir, to felicitate Dr. Dimple, ma'am. Sir, please remain on stage. I request Dr.
Sir, please remain on stage. I request Dr. Mamta ma'am to felicitate Vijay Bhalla sir.
Thank you, sir, for chairing this session and providing valuable moderation and feedback.
It is an absolute honor to introduce the distinguished scholar and expert in the field of diagnostics, infection control, and antimicrobial resistance, Dr. Gitanjali Kapoor ma'am. Let us extend a warm welcome to Dr. Gitanjali Kapoor ma'am to enlighten us with her valuable words.
We are also grateful to have Dr. Sunil K. Srivastav, sir, Delhi University, to chair this session.
So we request you to join us on the stage.
Yeah, it's my great privilege and honor to chair the session, and the speaker is a very esteemed one, a public health expert, Dr. Gitanjali Kapoor, who I know through Shobha Burul's days, because I worked on a lot of viruses and she was the one. So Dr. Gitanjali Kapoor, for the introduction, is a clinical microbiologist and with an expertise in laboratory diagnostics, infection control, and antimicrobial resistance surveillance. She has a strong public health background and experience across multiple international settings. Dr. Kapoor has worked with a wide array of stakeholders, including government agencies, academic institutions, hospitals, and public health laboratories, and global organizations across India, Africa, and the Middle East. And her contributions have been pivotal in developing and implementing infection prevention strategies, microbiology practices, and policies to combat infections, infectious diseases, and AMR, driving healthcare quality improvements and is strengthening public health systems globally, which is the dire need of the day. She holds a Master of Public Health from a prestigious Johns Hopkins University, Baltimore, and completed her fellowship at the Oxford, where she delivered a series of lectures on AMR surveillance best practices. From 2019 to 2022, she served as the AMR focal point for the Fleming Fund Regional Grant in Africa, leading initiatives to access AMR prevalence across 14 countries. She has also contributed to the WHO HIV and Hepatitis Control Program and the WHO Collaborative Center in Kuwait, and developed national infection prevention guidelines and state-level AMR action plans. Currently, Dr. Kapoor is the acting head of the One Health Trust, which is a very important organization, an international health research organization. There she leads the strategic initiatives, including developing a collaborative PhD program with the Birla Institute of Technology and Sciences, BITS Pilani. She also supports REACT Asia Pacific in strengthening AMR control strategies. So without further ado, I welcome Dr. Gitanjali to give her talk. Thank you.
Thank you, Dr. Srivastav, and thank you to
the host, Ravi, Dr. Ravi Kant and Dr. Myros, and everybody here, Renuka, she was really after arranging this beautiful conference, so I appreciate this gesture. So I understand time is running tight, so I'll be going a little quick. And my topic, as you can see on the screen, it's a programmatic approach. So I'm now shifting my gears to the program. That means we are now talking about you're on the field and you're no more in the hospital or in the medical college or academic institute. You're on the field and you have been given the task of, we are talking of AMR since morning. And if I give the task, say I collect about 10-15 people from the students and I say, okay, you have to go and implement AMR surveillance study. How would you do it? So of course it's going to be very, you'll get nervous. No, we have never done this. So it's not like that. It can be done. You need the right team, and we'll go over those steps in a very simple format. And it's not difficult, but of course you need the right people in the team to get that implemented. Many things have already been covered, so there will be a bit of, I think, overlap from what the speakers before me have already said, but then my slides will cover it to some extent. AMR, we all know, it is a natural evolution. It just is happening. So we cannot stop that natural evolution, but as you've seen since morning, we've been hearing about various other man-made factors which exacerbate it. This could be either if there is a lot of bacteria or microbes in the environment, or there's a lot of misuse of the antimicrobial. So of course, when there is this pressure on both the sides, then the microbe on its own, it tries to bring up that camouflage and build the resistance. Apart from that, various other factors which are more of environmental related. For example, your pharmaceutical practices, your discharge of the drugs is not being done the right way, or the drug is not getting deactivated, etc. So if you see, various pillars are being touched upon. We are touching upon human health, we're touching upon environment, we're also touching upon infection prevention, which also can happen in the animal farms and in aquaculture. So this is basically a One Health problem. Now, I'll be having a series of slides. This is the first slide, which is going to basically talk upon the initial steps. So as I said, I have a group of 10-15 researchers here who are going to implement this AMR surveillance. So how will you do it? Say for example, you have to write a proposal, okay, or you have to bid for some funding grant. So you need to make a very compelling case that, okay, this is a genuine problem, AMR is a problem. So you have to write a problem statement. Now when you say a problem statement, you of course need to first understand the statistics. What is the burden of AMR in that particular area or region or country? So you have to write a problem statement. You also have to define your objectives, that at the end of that AMR surveillance, what are you trying to attain? So your objectives have to be very well defined. One person cannot do that. You need a team. So that team has to have people with different skill sets. A microbiologist, obviously, when we are talking of AMR, has to be on board. Apart from that, you need an IT person, you need data collectors, you need a statistician, and you also need people who are in the bigger circle, the strategic team. You need maybe people from the country or the national authorities on AMR, etc. And also you need to have lots of meetings. This thing is not something which can be done in one day or a week or a month. You need to have lots of engagements with everybody who has a stake in this particular project. So that's why we call it stakeholder engagements. And I'll go to the next slide first. I'm coming back on the problem statement which we talked about. So whenever you make a problem statement, you have to be aware about the statistics. This was touched upon in the morning by Dr. Myros. I'll not go over it. You all, those who are interested, you can look up on the net and you will come to know these are very standard stats, basically based on modeling. Now modeling is something different, and we are talking about surveillance right now. So you'll also need to understand the difference between surveillance and modeling. But real data is the best because it gives you most authentic and accurate outcomes in the end.
So these are the stats. The first table talks about the burden of AMR, which causes deaths, both associated and attributed. There's a difference between associated and attributed. I'm not sure if you people are keen, and this is just, I'm doing a bird's eye view over here, but there's a difference between these two terminologies, and also it has an economic impact, which is going to be really bad if we don't take action at this point of time. By 2050, as per studies done by Sir Jim O'Neill, and as per various other studies which have been done by a UK group of researchers, the Graham Group, and also by World Bank studies. Now, we know that these, as I said, these are all estimates. These are not the real numbers. These are estimates. But of course, to the extent we have, we can only build our further case on these existing figures. Now, these estimates are maybe not very accurate. There are multiple reasons for this. One is, of course, all of you have been asking questions of what do we do when this is there or that is not there. This basically is pointing out the fact that the health systems are weak. So we have gaps in the diagnostics, unavailability, the manforce may not be well trained. The way the labs are testing for AMR, that may not be standardized as per recommendation. So that's a very big gap again. And many a times, even if it's being done, it's not being reported. So various factors which lead to our current understanding of AMR not being to the mark. So when you're going to make a team, what all you have to consider, of course, is that the same responsibilities may not go on till the end of the project. So I led a study in Africa, and I covered 14 countries, and we had a lot of data with us, but we had a very small team. And what the team was actually doing was every member's role kept changing as the project kept evolving. The same role, you cannot say, okay, I'm a data collector today and I'll continue being the data collector in the end. No, but maybe you don't have a role then. So you have to keep learning on the go. You start learning how to do data analysis, you start learning how to do report writing. So your roles have to be very, very flexible, and you have to be prepared for that. Also, it's important when you have, a big multi-centric study, you need to engage your stakeholders. You need to keep telling them, because they have put their money on this particular project. So they need to know where are you, what have you been doing. So you have to have those regular interactions with all the different stakeholders, the funders, the country representatives, the hospital directors, etc. It's also very important to comply with legal and regulatory environments, because you are talking about patient level data. So this is, of course, maybe in India that thing has not come up in a big way, but in the US and in the UK they have proper rules and regulations that if you pick up patient data, you cannot kind of just spread it around. It needs to be properly masked, it needs to be de-identified. Now that's a different chapter and a different ball game. We call it data anonymization. It's beyond the scope of today's topic, but that's again an area where you all could be interested, and you can read about that. So after you've done all this first step, the next thing is, where will you go and collect your data? So you have to select a site. That's the first box over here, the site selection. How do you do that? Do you just randomly go and say, okay, I'll collect data from these? No, you can't do. So you need to first of all start from the scratch. You have to do a full landscaping of which all laboratories are there in that region, which is of your interest, where you want to see the surveillance, where you want to see the AMR burden. So you do that kind of a mapping, and after you've done that mapping, you also need to check each of those identified places for the quality of the laboratory. So again, you have to have a questionnaire which is actually sent out to all these identified labs, and then see when they return the questionnaire, they fill in their answers. Then you again analyze, these are the top well-performing labs as per the responses they have shared with you. And then you decide with the bigger group, which is your project team, okay, well, these are the top 10 or the top 7. Again, also depends on the budget that you have been given. If you have a huge budget, you can do a lot of labs. Small budget, you can't do. Sometimes you just want to do AMR surveillance in one hospital. So it's a single centric, that's much easier. And then you start collecting the data. Again, collecting data not easy at all, because you need to know what exactly are you collecting, right? You go to the lab, there is so much of information, so you need to be very sure, match your final, what do you want to write in the end as your final outcome. It needs to be tailored back, and then you start saying, okay, I need to know the patient's age, gender, for a female patient, pregnancy status, and then you can also come to, so these are the demographics. Then you can make more questions. Okay, we need to understand from the AMR perspective, what's the pathogen's name, what is the AST test results, which is the pathogen of interest. So again, we saw in the morning that WHO has given a list of different pathogens, critical. I don't think the last was really interested in hearing, but that's okay. I understand that does happen. Yeah, so you have these battery of bug and drugs. You have to really come down to the fact which bug drugs, so which of those combinations are you keen to look at the AMR rate, okay? And finally, when the data is collected on the field, when the data collector is doing the collection, he is actually faced with lots of challenges. When you do this, you will come to know. So again, as I said, when we covered these 14 countries in Africa for the first time, the study was never done. It was really challenging because most of the labs had paper-based records. So imagine you are getting this, not just one hospital, but so many hospitals. Literally, we had 16 hospitals per country and then 14 countries, so 16 into 14. And so many of them were paper-based. So then transcribing that and putting it on your app, and then again putting it back to the cloud, it goes to the data reviewer. So these are the ways these are the various steps you have to follow. And at the other end, when the data comes to us, when it came to me and my team, we had to review, we had to clean the data, actually row by row. We had to make lots of programs, okay, filter out the data which is irrelevant, rubbish data was there. They were testing wrong bugs with the wrong drugs. There is again a protocol. Those who know microbiology, they know you cannot test a gram-negative with vancomycin, or when do you test with which your antibiotic in the lab. So all those things have to be factored in when you are doing your data review. Finally, the data analysis. When everything is done, then the easy bit is of analyzing. So you have your numerator, denominator, you take out the rate, that okay, these many were resistant, these many were tested, and this is how your percentage is arrived at. I covered all this while speaking in the previous slide, so I'll skip this. Questionnaire I did mention to you. So as I said, you have different kinds of questionnaires throughout the study. First would be to identify the lab, so that is lab related. Then it would be, so lab related again, generic, and then about their quality systems. Then you also have a questionnaire on the patient level information, because basically when you say this is the AMR rate, it has to be tied back to what kind of patients had that resistance, or was it in the ICU, was it in the orthopedics department, or was it in a patient who was having ventilator-associated pneumonia. So you need all those different, so various kinds of strata and substrata can be done on your AMR rate. So based on that, this is not comprehensive, but this is a good number of variables that you should collect when you are trying to do a AMR estimation. I also talked about how do you anonymize your data. This is a highly niche area, but you will come across when you do your further studies, if you do an AMR assessment, what is masking, what is de-identification. Again, it also depends upon the law of your country. So this is very generic. There is a difference, but otherwise when we are all speaking colloquially, we use it in the same breath, that okay, masking, de-identification, but these are different terminologies, and those interested can look into the GDPR and the HIPAA guidelines. I covered this, so I'll skip this. Data analysis is again proportion, which is not, this is again very technical, but we need to have a definition which is laid out. What is the formula? What confidence interval will be used? So again, you have to have a statistician also on board to kind of guide you when the stats bit has to be put. I hope all of you also know about the international recommendation. CLSI is very commonly used. Also UCAST is there. So again, it depends upon the university or the institute to decide which one they want to use. When do you decide that? So we had from one hospital just about 10 isolates. Do you think we should interpret those 10 isolates, or we should not? Is there any cutoff that I need minimum this many number of isolate results? Yes, you do have it. So all this information is given in international recommendations, and those interested have to be very well aware of it, because you don't want in the end you just kind of say, okay, I did a study, but it's all jargon that you're presenting in the end. So everything should be as well done as possible. And in the end, of course, it has to be presented. Do not let your final information lie on your desk. Please keep sharing it. So it was a 4-year study which I have been talking about throughout. We had a presentation almost every 3 months at different levels, global, regional, even if there's a small conference like maybe at SGT if I'm having and I was doing the study, I can share my findings we have done. So it's just a way of knowledge dissemination, which is very important. And final report writing also has to be done in a very crisp and a clear way, so the audience comes to know what did you do, does it make sense. It goes through a lot of reiterations, but that's the way we do these kinds of global health studies. And of course, publish your findings as much as you can do in various small different kinds of studies can be made out of a big study. Lots of international documents are there to guide you on AMR. Of course, you don't expect that in 1 day or 2 days you will become an expert. Even no one can, even I cannot, and I realize that I had very good speakers before me, lots to learn from them, but we all are learning every day. So go through these documents, and many more are there. WHO gives you a very good guidance, so you can always refer WHO, and even our Ministry of Health has very good documents online. There are lots of global platforms. I'm not sure if you know about it, but good to at least know the word GLASS. GLASS is a WHO platform, Global AMR and AMU. AMU stands for Antimicrobial Usage Surveillance System. So mostly countries are sending the data to GLASS, and GLASS has very good information about what's the AMR rate. And then like that you have it in different parts of the world, you have different platforms. So this is my last slide, just summing up. We talked about anti-AMR. What is AMR? It is a One Health problem. We talked about reliable estimates are rare, and I gave the reasons on one of my initial slides, how to approach the surveillance on a large scale, and of course you have to share your knowledge for, again, seeing what are the various challenges, sharing that, so the next person who's going to do a similar study can learn from your study, and the systems need to be constantly strengthened. Thank you so much. I'll be happy to take up questions.
Thank you so much, ma'am, because we're actually running a little short on time, so we're gonna skip to the...
So, if there are any burning questions, she'll be happy to answer them. Otherwise, so, yeah. So, if she has her email, you can contact her on T, and she'll be happy to discuss. Thank you, Dr. Gitanjali, so much.
Thank you, ma'am, for your insightful and inspiring words. Your wisdom has truly enriched this session.
We request Dr. Sunil K. Srivastav sir to felicitate our guests, please, and present a token of appreciation.
I request Priyanka Aswal ma'am to felicitate Dr. Sunil K. Srivastav sir. A heartfelt thank you, sir, for chairing this session and guiding the discussion with your valuable presence.
we would like to invite the eminent academician and researcher, Professor Urmi Vajpayee ma'am.
To chair this session, let us invite Dr. Muhammad Kausar Niaz, sir, a molecular biologist specializing in cancer biomarker research with global experience in molecular diagnostics. He founded Abir Bioservices Foundation to combat cervical cancer in India, ensuring accessible screening, vaccination and treatment for underprivileged women. We are truly privileged to have them here with us today.
On to you, sir.
Very good afternoon to all of you. Very good afternoon to all of you. Am I audible? Thank you. First of all, I would like to thank the entire organizing committee for this wonderful session that is going on since morning today and tomorrow also. And also same time I'm honored and privileged, ma'am, to chair the session. And definitely I'm going to learn a lot of things today from ma'am as well. She is having vast experience not only in academics but also in the research. And I'm going to tell you something that is not written in here actually, that is given to me to introduce her actually, you know. So, yeah, just I'll take 2 minutes. Very important to, you know, introduce the guest actually today. And this is a humble request to all of you to just switch off your mobile phone at least for this lecture actually, because One Health is very close to my heart as well and very close to the need of the hour as well. And One Health, in short, healthy human beings is linked to healthy environment as well as healthy animals. What we eat, what we breathe, what we drink is related to the One Health actually. And today's topic, AMR, you know, novel drug discovery, vaccine development, everything is related to the public health. And the topic that has been given to Dr. Urmi is One Health approach with bacteriophages to mitigate the AMR. And I just wanted to add few things before introducing her. I was going through one important WHO issue that today morning itself, how that one family by UTI, they came across the infection Klebsiella and how they struggled throughout, you know, the journey and how the cost to the nation, to the patient and all, and how bacteriophage, the phage center that is across the Europe actually, helped them out, that patient to treat it, and now he's living with a healthy life. The entire report was published on June 24, 2024. I would like to again emphasize once again the importance of this today's topic. So Dr. Urmi Vajpayee is PhD in microbiology. She started her career from Acharya Narendra College, Delhi University, long back, when that college was started early 90s, and she was there one of the founder member of Department of Biomedical Sciences. She has n number of awards, initiatives. She established a lot of organization also to support this bacteriophage research. And one of the co-founder I would like to highlight is International Bacteriophage Research Consortium, that is in the name of IBRC, and she is a role model for all of us to bridge the gap between science and the society. Because I follow her through the LinkedIn actually, I can see apart from a busy schedule from the academics and the research, she always used to communicate the science to the society. That is very much needed, and it was very well emphasized by our opening lecture by Dr. Professor Ronnie sir as well, where we are lacking as far as science and society, the bridging the gap is concerned related to AMR, any other health issues as well. Thank you so much, ma'am. I know we are running late out of time, so I just request ma'am to start the session as soon as possible. Thank you, ma'am.
Thank you. Thank you so much, Doctor, for your kind introduction. And I've been threatened to be very short. And I think you'll be happy because, shorter talks are better for you. So in my topic, as you can see, there's One Health, the bacteriophage and AMR. So you have heard enough about AMR and One Health, so I'll try to skip. And I'll be going to focus on bacteriophages. So before I just want to start with two cases. One is a personally known Dadu Bhai, and on the left, and one is Tom Patterson from University of California. Both of them contracted infection, severe infection, life-threatening infection, sometimes 10 years ago. And one succumbed to it, and one got treated and got fined because of bacteriophage intervention. So Dadu Bhai happens to be a relative of mine, and we were just about to reach Georgia to get phages for him, but he succumbed. Whereas the Tom Patterson case, the world came together and he was given bacteriophages in time so that he could be saved. So as they say that one death is tragedy and millions of deaths is statistics. So for us, once we see even a personal single loss, then we are motivated to work in that direction so that others don't suffer the same. So these are the challenges of present time when we say One Health challenges, that you have nowadays there's animal farming, there is rapid human expansion, urbanization, all of these factors, and then the conflicted zones. These are very hubs for antibiotic resistant infections. So what to do when we know that we are all connected? It's not just human health which suffers because of antibiotic resistance, but as my previous speakers have mentioned, the animals, plants, and the environment also. All of it gets affected so severely. So then what's the way out? So what are the solutions? So again, something like solutions is not necessarily you have to be in research or you have to be doing the same science to bring solutions, but you can also bring solutions by just creating awareness about the issue, that there is something burning, there is something which needs to be addressed. So creating awareness, as is being done by SGT today. Non-pharmaceutical interventions such as simple as like hand wash, hand hygiene, this alone can prevent so many infections. So this is something like everybody can do. And obviously antibiotic stewardship means responsible use of antibiotics in all sectors, humans and plants and animals everywhere. And obviously we need drugs, new drugs, as in the morning we learned that we need to discover new drugs. And in that category, we have to see that we need to find solutions which impact all the sectors. So therefore, when we go ahead now, if we think, though it's a newly minted coin term, One Health, for last few decades, but then if you see every organization, every civilization uses, they have emphasized on connectedness of different sectors. So it's a very old concept, age-old concept. And to understand the importance, there is a quadripartite agency which is comprising of WHO, WAOH, and then you have FAO, etc. So these stats, as you know, these are very grim. And when we say AMR, so then bacterial AMR is basically AMR because of resistance to antibiotics, which is bacterial, which treats bacterial infection. So last line, if you can see, it's not just health, but it is also, it really is going to crash economy, because the impact of AMR is predicted to cost $1 trillion by 2030 and cause the world to lose 3.8% of GDP. We just saw what kind of economic losses we saw in COVID. And it's a very ongoing pandemic, not visible as much, but these are like scary statistics. So how did bacteriophages catch everybody's attention? How many of you have heard this term, bacteriophages? I don't know how many of you are from biology. Okay, that's not bad, quite a few. Thank you. So, when this World Economic Forum in 23, when they listed bacteriophages as top 10 technology, top 10 emerging technologies, the world sat up, and I got calls from so many people who are non-biologists, non-even science people, what are phages and what should we do? So, and also WHO kind of endorsed them some time ago. So what are bacteriophages? If I define them, these are viruses that infect bacteria. As in, like coronavirus was infecting us, so bacteriophages are viruses which infect bacteria. So they are nature's way of keeping bacterial population in check. Otherwise, they'll be like drowned with bacteria. And so they're very abundant. They're estimated to be most abundant entities, and they're very, very specific to their host. So unlike antibiotics, I'll skip this. And so bacteriophages were first observed in India by a British physician, and that was the time when there was a cholera epidemic. There was an outbreak, and then he observed that somehow Ganga and Yamuna water were not getting bad. So this British physician, Ernst Hankin, he observed that what's going on, why is the water not going bad? But that time there was no transmission electron microscope, and therefore nobody could see what they were, but he could just see, filter it, and something which is coming in filtrate. Likewise, in 20 years hence, Frederick Todt and then Felix G. Rell, they also independently observed some antibacterial activity, and that's where the phage started being used as antibiotics. And so they have a very historical relevance, but now because of the antibiotic resistance, they are gaining traction again. So why phages were forgotten? Because penicillin became a blockbuster drug, and after that so many other new antibiotics came, so they were like forgotten. Also, pharma industry and the geopolitics of the time also was not interested in taking phages further. And third was that Felix de Rel was also not there. But today, because of this surge in the antibiotic resistance, there is we call now phage therapy in its second century. And now the publications have grown from 2000 to, from 4 in year 2000 to 579 in 2024. And there are about 50 biotech companies who are developing phage-based products. There are clinical trials going on in phage therapy in different countries, as you can see, maximum in North America, but also in, at least you can see it's happening in Asia. Phages also act as antibiotics adjuvant, but I'll skip this. Now, because antibiotics are not just used in human medicine, but also in animal medicine, so, and also as preventive measures. So, phages can we replace antibiotics, or can we complement antibiotics with phages, especially in farm, because where 70% of antibiotic is used. So we normally associate antibiotic resistance with humans misusing it, rightly so, but then animal sector consumes a lot of antibiotic, and that's where if we can, replace antibiotics with phages, we can drastically bring down the consumption and therefore the resistance also. And there are several reports which show that the animals also get treated by phages. So if I just have to compare, give you an analogy between phages and antibiotics, well, this guy on the right, everybody, how many of you are familiar with this person? Excuse me, this guy, Olympic, Mr. Cool? Okay, so then maybe this audience doesn't know. So he was in the Olympics, he is known to be a shooter, and he is so precise that he got an Olympic gold medal for this. And likewise, bacteriophages are very specific to their target. Unlike antibiotics, which are like a grenade, when you throw, so it destroys a lot of area around. So because antibiotics being broad spectrum, they tend to damage our microflora. So that is one of the major advantages of bacteriophages as antibiotics. And given this background, I'll just briefly take you through what we do at ANGC on this area. So my lab works on mycobacteriophages because we are trying to find solutions to TB. And these are three strategies. One is small molecule inhibitors, mycobacteriophages, and bacteriophage-derived enzymes. I'm going to focus only on mycobacteriophages. Because I don't know if I'll run short of my time, so I want to thank all my collaborators, funders, and my students. And we do phage hunting. From phages are found where bacteria are found, as simple as that. So wherever you find more bacteria, you're likely to get more phages. So you have to collect samples. And then you have to, we have developed this standard operating protocols to screen samples for presence of phages, which we desire. So these are the phages, and as at the bottom you can see that, these are like clear zones which tell that phages are present in samples. And these are like the transmission electron microscopy of phages to show how they look like. And we collect samples from all over the country, and we have a collection of about more than 750 we have processed more than 750 samples, and we have a collection of 300 phages which are different from each other. This is how the phage bank looks like. And we keep collecting and we keep getting them screened against pathogenic bacteria and MDR strains. And then as for any drug, you need to characterize. So bacteriophages need to be characterized to understand them well. And for that, you need to, look at their morphology, their protein profile, their stability profile, their biofilm disrupting ability, and most importantly, their genomic characterization. So we screen this is just to give you a snapshot that we screen our phages to see if they can inhibit not just planktonic cells, but biofilm. So biofilm basically is like, when bacteria get together and form a colony as in a city where they don't allow outside things to come in. So they are major contributors to antibiotic resistance. So if phages can disrupt or inhibit biofilm formation, they can contribute heavily to prevent or to mitigate antibiotic resistance. Yeah, these are the numbers. So on the x-axis, y-axis, we are showing the growth, and on the at the bottom are the phages, which have given shown some activity. So we compare that how many, like this one is a very good effector against biofilm, and this one is not able to do much. So we just compared the two and we identify the ones which are biofilm degraders or disruptors. Then, there's phage genome analysis is important. Why? As there was question about sequencing, because bacteriophage genomes may have genes for some antibiotic resistance gene or gene for a toxin or gene for lysogeny. So we don't want these genes if we want to use phages as drugs. So we characterize phage genomes to know that whether these genes are present. If they are present, then we better remove them. So finally, we have phages which we have been testing on MTB, which is the TB causing bacteria. And this slide shows that when we use these phages from our lab, this is not from our lab, this is a reference phage, but we have phages from MTB phages in our lab also. So when you treat a mice challenged with MTB, and then when you give doses of phages, and then once the animal is sacrificed, then we look at the load of bacteria, the organ-wise distribution. And this tells that not only phages are able to take, mice can take it up, but it also spreads and goes to organs like liver and lung and spleen and brings down the load, which is very, very promising because MTB particularly because it's an intracellular pathogen. So this tells that this has a lot of scope. And besides that, I don't know, I'll just briefly tell you that, so bacteriophages, once you have them, you can have a bank, characterize them, purify them to clinical grade, and then do preclinical studies to identify good killers, can they do. So then we also work on endolysis, but that I'm not going to talk in today's presentation. But what I want to summarize is that the phages and bacteria, basically what are their advantages? Why are we talking about bacteriophages? Particularly because, antibiotics, we are running short of antibiotics. So they can kill both antibiotic susceptible as well as resistant pathogens. They can inhibit biofilms. They can act with high precision, so they don't cause collateral damage as antibiotics do. They are therefore safe for commensals in symbiotic flora. They can synergize very well with the antibiotics. So that's why, it's very good that if you use them in combination, both can be very effective. And the immediate challenges, I think if you have questions, you can ask me this. These are the phage products which are already there in market for both human therapy as well as for animal therapies. And there are phages which are being used for in treatment. And I wanted to also say, because it's a university, that we need to do phage research. It's a very simple research, not like very expensive like antibiotic drug development. So phage research in education and innovation can involve a lot of students, and if there are small projects which students can do, then we can build them gradually, contribute to building towards the bank. And creating awareness and on phages are done through various platforms as I was introduced about. So these experts have brought a lot of awareness about phages, and to conclude, I want to say that AMR is a pressing global issue, and bacteriophages offer a very promising alternative to antibiotics. Lot is not being done, so we not only have to do research, but we also have to campaign for them because people don't understand and there's a lot of skepticism. And we need multidisciplinary effect. It's not just that microbiologists work on this phages, and therefore everyone can contribute, whether they are students, researchers, policymakers, and the public. So with that, I thank you, and thank you for your time, and thank you for making me speak so fast. Thank you.
Thank you so much, ma'am.
A heartfelt thank you, ma'am, for your enlightening words and for making this session so meaningful. Your insights have truly left a lasting impact.
We request Dr. Kausar Nayak sir to felicitate our guest, Dr. Urmi Bajpai ma'am.
I request Renuka ma'am to facilitate Dr. Niaz, sir. Thank you, sir, for expertly chairing the session, providing valuable guidance and enriching discussion with your expertise.
Ladies and gentlemen, it is a delight to introduce an exceptional scientist, renowned structure biologist, and respected professor at AIIMS Delhi, Dr. Sujata Sharma ma'am. We are excited to have her here with us.
Furthermore, we have the distinct pleasure to invite Dr. Mamta ma'am, Principal of BM College of Pharmacy, to chair this session.
We request Dr. Mamta ma'am to introduce our guest lecturer.
Namaskar to all the dignitaries and my lovely students present over here. Due to the lack of time, I just give a brief introduction of ma'am. Dr. Sujata Sharma is a professor at the Department of Biophysics of All India Institute of Medical Sciences, New Delhi. She has contributed in publication and over 200 papers in international journals and several patents. Madam has received various awards for her contribution in the science and literature. She has received a letter of appreciation by the Honorable Prime Minister of India for her book COVID Promise and Tumhara Bold, which promoted understanding of COVID among children. Madam had not only up to the professor, but she is having her own YouTube channel, that is Popular Science. I request Dr. Sujata ma'am, please come on the dais. Thank you.
Can I have the lecture? The lecture. I'll make this real quick because I've been told that time is short. So the title is Unlocking the Power of Lactoferrin, the Role of Hydrolysis in Enhancing its Potential. And of course, thank you Dr. Renuka and all the other members of the organizing committee for inviting me. So I'll go back to 1949 when lactoferrin, now as the name indicates, it's a red colored protein, red because it's iron binding. And this protein was discovered in 1949 by Dr. Murray Goldstein. And at that time, he just said that it has an antimicrobial function. And then it was discovered that this protein is found not just in human milk, but it is present in the milk of all the mammalian species. And it was concluded that it's mainly required for the defense and development and the nutrition, and mainly for the protection of the newborn baby. So why I actually made that Superman kind of infographic over there, because lactoferrin is like a Superman for babies. And then it was seen that it is not just in colostrum, but it's in many exocrine secretions, most of the exocrine secretions in mammals. And it was also seen that its concentration increases whenever there is inflammation or any kind of disease. Then more functions came about, and it was seen that it's not just antimicrobial, but it has a role in immunomodulation, wound healing, anti-cancer, anti-diabetes, and many, many more. So what we wanted to do was that we wanted to elucidate the structure, the three-dimensional structure of lactoferrin. So this, of course, I have not gone into the steps of purification of lactoferrin, but this was the three-dimensional structure. As you can see, it's got two lobes, N lobe and C lobe, and both contain an iron-binding site. So the idea is that when you ingest lactoferrin in milk, then obviously it gets hydrolyzed by various proteases that are present in your gut, and also you have microbial proteases that attack it. So the question was that what happens to lactoferrin when it is in touch with proteases. So we tested three proteases, proteinase K, trypsin and pepsin, to see what happens to lactoferrin. Does it remain whole, or does it get cleaved into small peptides, or are there N lobe or C lobes remaining? So this is, in conclusion, what happens was that in lactoferrin and N2 domains were only present with trypsin and pepsin, and in C lobes are produced by all the proteases, And there was a part of lactoferrin that was 45 kilodalton that was produced only with trypsin. So why did we focus only on the C lobe? So there were three reasons. The first reason was that while N lobe is only meant for antimicrobial functions, C lobe had many other functions. So most of the multifunctional properties came from the C lobe. So we wanted to focus on the C lobe only. Also, it was supposed to be more resistant as compared to the N lobe and more stable, and of course its functional properties as I already mentioned. Also, when we looked at the sequence of the N lobe and C lobe, we saw three segments which were present in C lobe and not present in N lobe. That indicated that this probably could be the reason why it has more functions than N lobe. Then, of course, we went through the isolation and purification of N lobe and C lobe after the hydrolysis. Won't go into them. And then we crystallized C lobe from three proteases: trypsin, chymotrypsin, and trypsin. And this was finally the structure of C lobe of lactoferrin. And we had three queries: what are the NNC termini of these three C lobes? How is C lobe preserved even in the presence of protease? Because proteinase K is so aggressive that it cuts your protein into very, very small pieces. So that was the question. And of course, what is the functional relevance of three segments in C lobe which are not present in N lobe? So we found that in all the three cases, the termini were intact. And that was surprising because, all three proteases have different specificity. Trypsin has a different specificity as compared to proteinase K. So we found that the peptide where all the three proteases was cutting is actually, it has a sequence in such a way that trypsin, which will cut at the carboxyl side of R341, would cut it there, and pepsin, which would cut at the amino side of tyrosine, would also cut over there. So this showed that lactoferrin has simply evolved itself in such a way that it can resist proteolysis. Then the next question was that while it can resist proteases, how is it that it can even resist proteinase K, which is so aggressive? So we found that C lobe, there is a peptide in C lobe which goes and inhibits. So your C lobe is also a protease inhibitor. It is a protease regulator. And of course, these are the functions of protease regulators, and that's why most likely it has got many functions. It prevents uncontrolled proteolysis, maintains cellular homeostasis, and controls blood clotting, etc. So we moved on to another function of C lobe, that is, how does it reduce NSAID-induced gastropathy. NSAID is the normal, aspirin and Disprin that you take, and these are over-the-top kind of medicines that you get even without prescriptions. And if you take them in excess amount, it causes gastropathy. And it is seen that lactoferrin is reducing that kind of gastropathy. So we wanted to see the structural basis of this kind of function. So this is just to show how in various common ailments, arthritis, headache, people are in fact overdoing when they're taking NSAIDs, and that causes gastropathy. So we took 4 commonly prescribed NSAIDs: aspirin, indomethacin, diclofenac, and ibuprofen. And then we did some animal studies where we studied the intragastric bleeding and gastric inflammation. So we divided the animals in 2 groups, and we saw that the group that had C lobe, there was a reduction in intragastric bleeding as well as gastric inflammation. But the other group was just like, as expected. So this graph shows how it's being reduced. And then what we did was that we crystallized that particular C lobe which contained NSAID, and we saw that C lobe, this NSAID is going and binding to the C lobe. And this is the, this is the NSAID binding site, which is separate from the iron binding site. So that shows that this site is evolved in such a way that it does not affect the iron binding capacity of lactoferrin, yet it is able to chelate the excess NSAIDs. And that is the reason why C lobe or lactoferrin is reducing gastropathy. Of course, we went into deep analysis that what is the site made of, so that if tomorrow we want to do engineering or make a drug which can reduce gastropathy, we can do it like that. So we saw that it has got 2 components. One was hydrophobic, that is a beta strand, and then it had a twisted fork made by 2 C-terminal alpha helices and certain residues which bind to NSAID. Next, going to diabetes, because again, there were reports that C-lobe reduces diabetes also. So we took two very common sugars that are consumed nowadays, glucose and fructose. And we again crystallized C-lobe with them, and we saw again that glucose and fructose are going and binding at the same site that your NSAID was going and binding. So that clearly showed that this is a multifunctional binding site in C-lobe of lactoferrin, which does not affect the iron binding, but it's a well-defined pocket on the surface, and it's easily accessible to small molecules. Next, we wanted to, since there were reports, this work is mainly trying to establish the structure-function interrelationships. So there were reports that lactoferrin also prevents certain influenza viruses, and SARS-CoV is also recently seen that lactoferrin is reducing that, and influenza virus. Yeah, I'll just finish it quickly. So again, just to show that C-lobe has three loops, which N-lobe didn't have, as I said in the beginning. These are the ones which are actually responsible for stopping the viral entry. Just in the end, to show that we are doing certain clinical trials of lactoferrin at AIIMS, and our department is collaborating with the Department of Medicine, Microbiology, and RP Center for Ophthalmic Sciences, and we are checking out how lactoferrin is reducing anemia with the Department of Medicine. This is just the design of the clinical trial, and of course dry eye, as since there are a lot of students here, and we'll just to tell you that since we all, not just students, we all tend to look at the screen too much. We develop dry eye, and lactoferrin reduces, it is helping in dry eye also. And this is again the clinical trial this thing, and these are the cover pages on which C-lobe structure where we published came. And this is my book, The Secret of Red Crystal. So I've written my autobiography about how I did this work, and I started this as a student, and I'm still working on it. And finally, thanking my group at the Department of Biophysics, AIIMS. Thank you.
Thank you so much, ma'am, for your insightful words and making this session truly enriching. Ma'am, please remain on stage. We request Dr. Mamta ma'am to felicitate our guest speaker. We request Dr. Poonam ma'am to felicitate Dr. Mamta ma'am. Ma'am, please join us on stage. Eminent delegates, honorable guests, and respected dignitaries, as well as students, as we come to the end of day one of this international conference, I would like to take a moment to appreciate the enthusiasm, intellect, and dedication that each one of you has brought today.
As we conclude for the day, I encourage you all to reflect on the insights gained and return tomorrow with the same energy and enthusiasm. Wishing you all a refreshing evening. See you on day 2 for another day of learning and discovery.